delighted to be your moderator today. This session will run for 1 hour. We will take 2 presentations followed by a question and answer session. Kindly join our discussion through the chat, and we will be responding to some of those questions in real time, and part of it will be dealt with during the question and answer time allocation. We do have language interpretation services. Please keep to one of either English, French, or Portuguese, and do not be on the off channel. Our session slides and recordings will be shared with you as soon as they become available. And so that's a key point to note. Always shared with you either through your mails or through our multiple social media handles, so that you can make reference at a later date to the materials that are always very important to look at again. Today we focus on transforming pediatric HIV care through test integration and the introduction of the Xpert HIV-1XC. And of course, we'll be diving into this in a lot more detail when my presenters get the chance to begin. We know that early initiation of antiretroviral therapy in HIV-infected infants can save lives, yet coverage of some of the critical interventions among children actually remain low. And due to the slow progress reported in scaling up access to treatment for children living with HIV, it becomes inevitable that achieving the 95-95-95 UNAIDS targets remain challenging. There has been a renewed focus, I have to note, to meet the 95-95 targets by 2025, including the launch of the Global Alliance to End AIDS in Children. The renewed focus has been called to strategically target more decentralized diagnostics and clinical management for children exposed and living with HIV, as well as integrating with maternal, child, and adolescent services at facility within the communities that we serve. The 2025 targets also underscore the need for diagnostic technologies that are easy to use, that facilitate safe disposal of waste, and are cost-effective in the wider effort to realize the right to health and other human rights and other goals within the United Nations 2030 Agenda for Sustainable Development. And in today's session, colleagues from Cepheid will provide us with some overview in the new developments in the space related to diagnosis of HIV in children and infants. And then that will be followed by CHI Nigeria, that will be sharing with us their experience in integrating the EID through a pilot study that they did, and also they are scaling it up and transitioning to the use of the HIV Qual XC. So they will discuss this and highlight the added value for what integration means to scaling up testing, but also using the new technologies that have been brought up. And colleagues, to take us through this, we have Dr. Gwen Stevens, and Dr. Gwen is a Director of Medical Affairs with Cepheid Diagnostics and Life Sciences based in South Africa. After Dr. Gwen's presentation, we will then have Mr. Jibrin Kama, who is an Associate Director with Access Programs for the Clinton Health Access Initiative from Nigeria. Let me now take this opportunity to hand it over to Dr. Gwen to take us through the first segment of this presentation before we then get to Kama. Over to you, Dr. Stevens.
Thank you so much, Francis, and thank you for the introduction. Can you just confirm that you can see my slides and all is in order?
Yes.
Okay, super. Right, well, good morning, good afternoon, and good evening to everybody on the call, and thank you so much to ASLM for providing us with this platform to introduce one of the new products within Cepheid that really speaks to a gap and a need that we all are aware of, particularly in our region. I'm really honored to be representing Cepheid today to introduce this new test called the Xpert HIV-1 Qual test. By way of introduction, I will just provide sort of an overview and put it in context. So as we're all aware, in HIV diagnosis, it's crucial to understand that nucleic acid testing, or NAT testing, as we all know, detects the virus much earlier than serology-based assays, and that NAT tests really target the genetic material of the virus, and in doing so, enable detection as soon as 7 to 10 days post-infection, whereas serology typically detects antibodies, and we know that they only become positive 2 to 6 weeks after infection. And really, so this highlights the need to incorporate NAT into any early diagnosis protocols that allow for prompt intervention and improve patient outcomes. So if we have a look, of course, our focus today is early infant diagnosis, but we can't neglect the fact that NAT tests also play a critical role in HIV diagnosis in key populations in general, who are usually disproportionately affected by HIV. And they offer several benefits in these population groups as well. Of course, by identifying infections very early on, interventions like effective treatment can be initiated very swiftly. This reduces the risk of onward transmission within these vulnerable communities. And also, early diagnosis facilitates timely access to comprehensive care, which includes ARVs, support services, all reducing HIV-related morbidity and mortality rates. If we have a look at the right-hand side of the slide today, in early infant diagnosis, NAT testing has played a role for quite some time, and it's even more pivotal due to the presence of contaminating maternal antibodies, which we all know interferes with serology-based tests. And NAT testing circumvents this challenge because it directly detects viral DNA, which enables accurate diagnosis in infants, again, ensuring accurate and timely access to life-saving treatment and prevention measures. And the importance here of near-patient testing cannot be overstated, and we'll talk a little bit more about that later on. But really, in a nutshell, it enables rapid and accurate diagnosis at the point of care, which eliminates delays that are sort of traditionally associated with any centralized testing, which allows immediate initiation of treatment. And it's particularly crucial in resource-limited settings where I live, where a number of you on the call are based, where access to healthcare infrastructure is relatively limited and loss to follow-up of infants is really commonplace. So if we go back to its role that it plays in key populations, in adult populations, really very pivotal here, because as you're aware that during this early phase of infection, although the viral load may be very high, often serological tests may still be negative due to the lag time we see between infection and antibody production. And NAT, as we know, directly targets the DNA or RNA of the virus, which enables very early on detection, which reduces transmission, allows timely treatment initiation, prevents immune damage. And this is a very important and key benefit, really, is that early treatment really helps preserve those CD4 cells that are depleted so rapidly during disease progression. And really, this sort of mitigates the long-term impact on immune health that we see. So many, many advantages. And the NAT test's ability to detect acute HIV infection in adults in these vulnerable key population groups really is instrumental in breaking the chain of transmission and improving health outcomes for all individuals. And if we have a look at the issue we face in children, of course, there are still huge gaps. As of the latest available data, the global state of HIV in children remains a significant health challenge, particularly in low-middle income countries, particularly in sub-Saharan Africa. And despite the great progress that some groups and some regions have made, there still remains an ongoing gap, particularly in testing in these very vulnerable at-risk populations. And according to UNAIDS, an estimated 150,000 children were newly infected in 2022, with approximately 2.8, almost 3 million children living with HIV. And despite our advances, and there have been many in the prevention of mother-to-child transmission, particularly in sub-Saharan African regions, many children still lack access to essential services like early infant testing. If we have a look at some of the data that's out there, it's quite alarming, because according to the UNAIDS, only 59% of HIV-exposed infants actually receive testing within the first 2 months of life in Eastern and Southern Africa. And the picture's even worse in West and Central Africa, where we see only 36% of children receiving access to testing. Without testing and immediate treatment, we know that 30% of these infants will die before their first birthday, and more than half of them will die before they reach the age of 2. And we do know that a child's likelihood of dying from an AIDS-related illness declines by 75% if they receive antiretroviral treatment within the first 3 months of life. So we understand the picture around HIV transmission from an HIV-positive mom to her child, which can occur in pregnancy, labor, delivery, or breastfeeding. We understand the concept of vertical transmission. But in the absence of any interventions during these stages, like timely testing and treatment, we know that the morbidity or mortality will remain alarmingly high in these population groups. Up until recently, testing for EID needed to be performed in conventional laboratory systems that required significant infrastructure and training, and still happens. Centralized testing for EID is still the sort of predominant testing modality across the globe, particularly in low middle income countries. But now early infant diagnosis by PCR can really be performed outside of the lab, using innovative point-of-care molecular technologies that really have reduced the requirements for these very large, complex infrastructure and training requirements. These technologies allow for tests to be performed in close proximity to where patients are actually receiving care, and they can be performed by either laboratory professionals, but not necessary to have a laboratory-trained technician. They can also be performed by healthcare professionals or even lay healthcare workers that have received the appropriate training. And the WHO now, in their recent recommendations around early infant diagnosis, really recognize that point-of-care molecular NAT testing offers a real tangible opportunity to significantly reduce the time it takes healthcare professionals currently to diagnose an infant with HIV and to initiate treatment in a timely fashion. This is one of the EID algorithms recommended by the WHO, and you see they recommend EI testing at multiple time points along that cascade. So let's move on then to the matter at hand, and that is the introduction of Cepheid's new Xpert HIV-1 Qual assay, which in our region is predominantly, the use case is predominantly around early infant diagnosis. But of course, in terms of product overview, it's an in vitro NAT test for the qualitative detection of HIV-1. And it uses the automated gene Xpert system that we're all very familiar with across the continent, particularly around our TB programs. It detects HIV in 2 sample types, that is dried blood spots and EDTA capillary or venous whole blood. And it has a claim for the diagnosis of HIV in infant, adolescent, as well as adult populations. And as I mentioned, the test is intended for use by laboratory professionals or any appropriately trained healthcare professional. And an additional advantage is the fact that it now has a claim for near patient testing environments. But let's have a closer look at the differences between the assay that you may be familiar with, which is the previous version of the assay, and this new version that we call Xpert HIV-1 Qual XC. So the old assay used to be a single target assay. XC, which stands for extended coverage, is called so because we now have a dual target assay. So the targets include the LTR as well as the POL region. And of course, this mitigates any risk associated with a misdiagnosis because of a rare mutation that may occur in the target region. The other significant improvement in this product, where you will all be really happy to hear about this, is the fact that we no longer have GTC in the assay. And it's now far easier and far safer to dispose of these cartridges post-PCR. In addition to that, there is also what we call an early assay termination. So if the assay shows to be positive, we can stop the assay earlier, which means the time to result is reduced. So what we see for whole blood, for example, that the early assay termination time is around 63 minutes for an HIV positive patient. And when we look at DBS, the early termination time to result is about 76 minutes. So it's reduced the time to result significantly, which has a huge advantage if we're talking about near patient testing, same day test and treat. Of course, it has a claim for all populations, as I mentioned, but we now include a specific claim for early infant diagnosis. Another very sort of welcome advantage and evolution is around the workflow. So it's still, the samples are still DBS and whole blood, but it's a much simplified pre-analytical process. Actually, there is no pre-analytical process. So your whole blood or DBS are just put directly into the cartridge, and I'll show you a simplified workflow and a diagram in a minute, but there's no pre-analytics required, which negates the need for any other accessories that may have been required for the elution of blood with the DBS, for example, which occurred in the previous version of the assay. Of course, it also has a near patient and point of care use. We've seen all the data. We've seen the recommendation by WHO that this is where we should be moving in the early infant diagnostic space. And now we are not limited to the use of this product by laboratory technicians or technologists, but any trained healthcare worker is able to use the product very effectively and efficiently. So let's have a look at that workflow. It's a much more simple workflow. It runs on the Gene Xpert, so there's a flexible throughput. And of course, I've already alluded to the faster time to result. But if you have a look there, all it requires is the addition of either 100 microliters of venous or capillary whole blood directly transferred into the sample chamber in the cartridge, load into the Gene Xpert, and off you go, and the results come out in really good time. With respect to dried blood spots, we've removed all the pre-analytics that were required in the previous version. You simply remove the dried blood spot either by cutting out with a sterile scissors or punching it out, depending on your card, popping that DBS directly into the cartridge and load and go. Here is just the diagram showing you the whole blood workflow particularly. And as I mentioned in the previous slide, very simple, very, very limited hands-on time for the whole blood assay. And now that is applicable to the dried blood spot assay as well. We have a look at what data is out there in terms of the impact that near-patient EID testing has had. There are a number of really good data sets out there, most of which have been published. I think everybody should be aware of the large study that was undertaken by the Elizabeth Glaser Foundation in 9 African countries. They're listed there, which really showed that point-of-care testing was highly effective when compared to conventional central laboratory testing for EID. The results were returned to caregivers in 98.3% of the cases in less than 30 days in the point-of-care arm versus only just over 18% for conventional testing. Then the median time from sample collection to the caregiver, result to the caregiver, was of course 0 days at point of care versus 55 days with the conventional centralized testing. And the number of infants diagnosed and initiated on ART, which really is what counts, within 60 days, increased from 43% to 92% when we looked at the point of care versus the conventional testing arm. And of course, the median time from sample collection to ART initiation was 0 versus 49 days. And the median age at ART initiation was 1.6 versus 3.3 months. So children were being put on really highly active antiretroviral therapy, at 1.6 months, so 1.5 months earlier, 90 days earlier than were in the conventional arm. And very importantly, and of note to mention, that the cost per test result returned was significantly lower for point of care than conventional testing. And it was shown to be cost effective compared to the standard of care. It's felt to be more cost effective in the long run, as it shortens the time between diagnosis and treatment for infants, which really results in fewer children who go on to become sick from undiagnosed HIV infection. And this has been published for quite some time. It appeared in the literature in 2021. And then when we talk about our new product, the performance thereof, there are 2 key publications that have appeared. And the one was a study that was undertaken by Dr. Nomondi Bengu and Professor Philip Goulder here in Durban in South Africa, where they looked at the feasibility and the performance of the XC assay versus the older version of the Xpert HIV Qual assay, and showed without a doubt that the XC assay, the new assay, outperforms the Xpert HIV-1 Qual assay in detecting HIV infection in newborns, so particularly in the EID environment. And then in addition to that, Professor Matilu Mao and Priska Bwana in Kenya also looked at the usability of this particular assay, the HIV Qual XC, using DBS for EID in field settings in Kenya. And they too showed that the Qual XC assay was highly accurate and also had a much simplified workflow and was easy to use and easy to interpret in the field settings in Kenya. And subsequent to that, the literature now is littered with publications around the feasibility of implementation of molecular NAT testing, particularly with the gene Xpert, using these assays in all hosts of different settings across the globe, and particularly in sub-Saharan Africa and other low middle income countries. And I'm going to end it there. And thank you all for your attention. And I will be happy to answer any questions. And just in closing, the evidence presented today really has underscored the potential of the Xpert HIV-1 Qual XC assay, its high sensitivity, specificity, ease of use, and feasibility in resource-limited settings really offers what we think is a beacon of hope in the global fight to eliminate mother-to-child transmission of HIV. Thank you, Francis.
Thank you. Thank you very much, Dr. Stevens. Very intriguing. Allow me not to start trying to just summarize anything here. We'll do both summaries at the end. At this point, let me introduce Jibrin Kama from Nigeria to run us through the POC EID implementation experience from Nigeria, and then we'll take the questions and comments at the end. Kindly continue to let your questions run through the chat. I know that Cepheid and the other teams from Nigeria are dealing with those answers as well. Over to you, Dr. Jibrin.
All right, thank you very much, Francis. Good morning, good afternoon, good evening, everyone. I want to first say a huge thank you to the ASLM team for the opportunity to make this presentation today. So essentially, we focused on presenting gene Xpert integration pilots implemented in Nigeria between March of 2021 and February of 2022. So just for context, it's important for us to understand what the need was in Nigeria and why we felt it was important to introduce point of care testing, especially for EID. So to do that, I just want to share some country context in terms of PLHIV population and sort of what the status of HIV was when we did this project back in 2021. In terms of national HIV burden, we have roughly about 1.8 million people living with HIV in Nigeria. Our national prevalence is about 1.4%. 12% of our burden are actually in children aged 0 to 14 years of age. And of course, EID coverage at the time was actually quite low. It was actually about 28% as of 2020, which is basically the baseline data that we worked off. And basically because of these major indicators, we thought it was important for us to address this by thinking of individual ways to help address these challenges.
Yeah, I think the voice is not clear. Yeah.
So
It's a bit unclear, yes. Kindly, let's continue and see if it gets better, Jibrin. The voice quality is not as good, but let's see if it gets better. Kindly continue.
So in terms of what challenges we wanted to address, we identified a number of challenges in our sort of laboratory system in terms of long turnaround time, high loss follow-up. And those are some of the major challenges that we felt we could address by introducing point of care testing. So the idea was just to really see how do we ensure that we're able to optimize testing, not just at the decentralized labs that we have these huge platforms, but also introduction of point of care technologies, for example, the gene expert machines, to help us achieve 5 key objectives. One is to be able to increase testing coverage. One is to be able to ensure same-day testing results. One is to ensure early initiation of treatment for HIV-positive infants. One is to be able to reduce loss to follow-up and ultimately improve client management. So fortunately for us in Nigeria, we have a huge number of gene expert machines available. And we thought it would be very important to leverage these machines by identifying which ones of those platforms actually have spare capacity to take on integrated testing. So this essentially shows you what sort of the continuum of care is. And I'm just giving you 2 examples, comparing conventional continuum of care or decentralized PCR labs versus the use of point of care technology to actually provide services to our clients. So if you look at the chart at the top, you have the client coming into the facility for their visits. The sample is collected, in this case EID. The sample is typically transported by a third-party logistics company or by the healthcare worker to the PCR lab. Sometimes PCR labs are very, very far away, or sometimes out of state, being transported to another state for testing. Of course, at the PCR lab, those samples are tested, the results are approved, results are printed. We have a 3PL come to pick up those results, or a healthcare worker comes to those facilities. The PCR labs pick up those results and then transporting them right back to the health facilities. Yeah, at that point in time, if the clients come back to the health facility to actually get consulted by the clinician to inform client management. So if the client is positive, of course, the patient treatment is negative. At least we have the final results with respect to that client. But one of the major challenges that we identified was that at some key points in this cascade, we're seeing really high loss follow-up. For instance, too many samples are transported to the health facilities, to the PCR labs. We saw high loss follow-up. We saw when samples are actually tested, results made available and transported back to the health facilities. We're seeing high loss follow-up. And ultimately, between when results are available at the health facilities and when the clients actually come back, we're actually seeing this high loss of follow-up. So we thought that what can we do to help address some of these challenges? And we identified based on work that's done in other countries that use of point-of-care technologies can actually help address some of these gaps. So if you notice at the bottom there, we're able to have the same continuum of care, but actually reduce that turnaround time from 3 to 6 months to less than 2 hours, maximum 1 day. And this was the idea around introduction of point-of-care technologies. So how was the implementation done? What level of care? What kind of healthcare workers do we leverage? What testing algorithms, capacity build, and of course, stakeholders that we work with to actually carry out this implementation research. So we designed this essentially across 3 major objectives. The first was to demonstrate visibility and impact of integrated testing for both TB and HIV program. So traditionally, the gene expert machine have been used to just TB in Nigeria. So this was an opportunity to actually leverage the same platform to integrated testing. The second key objective here was actually how do we describe the 7 delivery approaches to enable integrated testing and optimize linkage to care and treatment for those clients that we found to be positive. Then last but not least, we wanted to make sure we effectively operate disease testing and using the information to inform how we scale up the use of this platform for integrated testing. So we have 4 key expected outcomes from this implementation research. The first, of course, to inform policy decision making in terms of adoption of integrated testing, was making sure that we had impact, and of course being able to optimize that network. How do we ensure, how does this POC machine, how do we fit into the centralized network? How do we ensure we optimize testing capacity and have an optimized network across both centralized PCR labs and also primary care platforms? The second key outcome we wanted to get was optimized case finding. We wanted to be able to increase case finding, not just for TB, but also for the HIV programs. The third was, of course, being able to showcase successful model for integration, and of course, catalyze national level scale. Last but not least, we wanted to inform programming for deployment of high throughput platforms like GX16 and GX10. Just being able to show the impact that if we're able to integrate the opportunities for actually bring in high throughput platforms. So this is basically how we designed the study, and I'll talk about how we did the methodology over the next few slides. So just to give you some context, as I mentioned earlier, traditionally we're using the Xpert machine just for TB. However, we know the Xpert machine can run a number of different lists. For us, the priority diseases and test menus in country were early infant diagnosis. We wanted to also cover HPV and also HIV viral flu. But we need to also prioritize based on the fact that we want to leverage spare capacity of the existing machines that we had in country. So as a country, we came together and just prioritized that EID will take priority over HPV, and then HPV will take priority over HIV viral flu. So what you see basically in the slide is that we got some information around what the status of regulatory approvals were for the platforms for this assay, what kind of sample types could be used, and of course the time to result. So all of that was important to inform how exactly the situation was going to be implemented. So Nigeria has about 36 plus 1 states. So what we did, of course, we engaged the Federal Ministry of Health. We assessed about 28 gene expert sites across 11 states in Nigeria. And basically, the state that you see here, the states that we identify where we had gene expert machines, spare capacity to actually have integrated testing. So we identified about 8 states for us to actually integrate gene experts testing. So to your right is that it's my area to spend the next few minutes talking about, just to give you an idea of exactly what we had to do to actually achieve impact on this implementation research. So in terms of timeline, Q4 2020, when engaged with Federal Ministry of Health, specifically the National TB Program, the HIV program, and of course, National PMC tax team around the need to actually carry out the implementation research on integrated testing. In order to do that, of course, that's we to conduct an assessment. We basically visited the sites, we had the site assessment checklist. We collected a number of data for HR needs, for infrastructure, service of maintenance, disease burden in those states, the willingness of those sites to actually carry out integrated testing. We collected all that data to help identify any potential challenges that we need to address before we could actually carry out integrated testing. So as of Q1 of 2020, yes.
Like Jubin was talking about earlier, so in Nigeria, we had this, what a plethora of gene expert platforms that, like the first presenter said, we rightly knew we could use for multiplexing. So what did we do in Nigeria back in 2021? Actually, starting from 2020, if you look at the timeline on your screen. So in Q4 of 2020, we started with the stakeholders engagement because as most of you on this call know, the gene expert devices in most countries are run and managed by the TB program. So we needed to make sure that the TB program was on board of, for integrated testing. One of the challenges we had then was the TB program being skeptical about, EID or HIV program bastardizing the gene expert, and there will be issues with availability for the TB program. So the stakeholder engagement was very key to the success of this work. So we conducted that in Q4 of 2020. And then in 2021, we started the actual implementation of this multiplexing using the gene expert for EID POC. We started with developing SOPs that the healthcare facilities will use. It's important to know that before then in Nigeria, these gene expert machines were used purely for TB programs. So we needed to make sure that there were tools in place that the healthcare workers will use when it comes to EID POC, because this was the first time this was being done in the country. And again, like I said, we had to engage the TB program. And one of the things that came up from that engagement was, can you give us some sites to pilot this, this integration? And so some of the sites they gave us, we went in there, did the capacity utilization, and we had to ensure that the sites they were able to provide integrated services. So what does this mean? The GeneXpert machines are functional, all modules are functional, they have backup power, they have refrigerating system, they have cooling systems. So we went in, we did this both capacity and infrastructural assessments to make sure that these facilities were ready for integration. And when we did that, we realized there were some gaps, and we went and optimized the site. For instance, we see there were facilities that did not have power, make sure we provided backup power for them. Those are some of the things we did. And of course, we engaged Cepheid to ensure that the equipments were calibrated for POC EID, because recall again, it was just TB that was done on these devices. So we had to make sure that the devices were calibrated to conduct EID testing. And then in same Q1, we commenced training of the health workers on using GeneXpert for EID. And part of the training also include things like demand generation, just because before then they were used to sending the samples to PCR labs, like Jibrin talked about earlier. So we needed to make sure that the facilities were aware that in this facility, you don't need to send your EID samples anymore. You just need to collect the samples and send them to the lab, that and improve demand generation for EID services. And then in Q2 of 2021, we completed all the trainings, and then testing started. And we started collecting the data in terms of the testing, and then we conducted monitoring and supportive supervision to ensure that quality measures were in place for the testing and that data was being reported accordingly. And all the way from 2021 Q2 till Q1 2022, that span about 9 months, these facilities that the pilot facilities were testing, and we kept going back to ensure that the quality was in place. We're conducting monitoring supervisory visits to ensure that quality standards were being adhered to. And in Q2 of 2022, we facilitated the dissemination of the results from this pilot study. Next slide, please. I'm going to run through this. Next slide, please. So like I said earlier, the stakeholders are very important. Here, you're just looking at the list of stakeholders we have to work with and highlighting the need that this is a multi-sectorial kind of work. So we had to work with the TB program, the HIV program, our PMCC tax team in country, the funders, PEPFAR, KNCV, and the state programs. Next slide. So I kind of talked about this earlier. Next slide, please. I kind of talked about this earlier in terms of the selection, right? So how did the selection happen? We went to first of all, we had to select the states. And in total, in Nigeria, there are 36 plus 1 states. We ended up selecting 8 states for this implementation, and it was based on the TB volume, high TB or HIV prevalence, and then low. We wanted facilities that had overall low GeneXpert utilization. And the idea behind this is the fact that we did not want to go to a facility that was already, the GeneXpert already overutilized, and then there will be issues, right? Because remember the concern the TB program had from the engagements. We wanted to make sure that the facilities also had spare capacity to be able to integrate EID. And then we wanted to the site selection. We wanted sites where we had both HIV and TB services, because that's where you would have the integration will be made easier, because then you can now take the EID sample from the HIV clinic to the TB clinic to be tested. We also wanted sites that had functional GeneXpert machines, because you're not going to integrate when the devices are not functional, right? And then of course we wanted adequate HR to be able to ensure that this integration was successful. And then for the GeneXpert capacity, I talked about this earlier, we had a utilization assessment that went through a number of questions and criteria to ensure that whichever facility this integration happens has spare capacity to be able to conduct EID tests without negatively impacting the TB test. Next slide, please. This just takes a look at what the capacity utilization tool looks like. It's a very rigorous tool. So you set threshold to say, for instance, if this facility has an unused spare capacity of 50%, right? So what that means is that currently capacity utilization for that facility is currently at 50%, which means there's an extra 50% that we can integrate on. So there were a couple of criteria that were set, and based on that criteria and threshold, that's how we came by the sites that were selected, and we ended up with 19 sites across the 8 states that we mentioned earlier. Next slide, please. So in terms of capacity building, once we were done with all the assessment, capacity utilization, site optimization, the next thing was the actual training. And what did we do for the training? Again, like I said, this was around 8 states, and we trained a total of 180 persons, both the healthcare workers at the facility level and the implementing partners, as well as the state, the stakeholders in the state. And we had this across 19 Xpert sites. What cadre of health did we use? We had both the primary and secondary healthcare facilities as part of this pilot. And in terms of the cadre of healthcare workers, we had both nurses and CHUs for demand generation, but the actual testing was done by the lab focal person. And during the training, we covered the sample processing, demand generation, which I talked about earlier, because this is key to ensure that, it's not, we've integrated at the facilities, but it's also important that, the demand is coming, so they know that, oh, we now have POC for EID in the facility. And of course, electronic reporting was also very key, and biosafety and waste management. This was particularly very important because when we started the pilot, so recall if you look at the timeline I showed earlier, from Q1 of 2021, when we started the work, we started with the Xpert HIV-1 test kits. That's what we started with. So as at then, the biosafety and waste management was very, very important, particularly because of the GTC. Next slide. So again, I believe I talked about this already, the key thematic areas that we covered during this, both the training and the implementation. We needed to make sure that consumables were in the facilities. We wanted to make sure that waste management was taken care of. So for facilities that needed incineration, recall that for the HIV-1 Qual that had GTC, you need an incinerator of greater than 1,000 degrees. So we needed to make sure incinerators were in place, and where there were no incinerators, we had to think about waste management of moving it to cement factories that were close by for proper waste management. Of course, human resources, I talked about this earlier. We needed to make sure that there were healthcare workers in the facility and available to conduct POC EID testing, biosafety, and then for sample referral also, because we implemented a pilot that some facilities had to send their samples to the hub facility that had the Xpert. And then testing volumes, I talked about this. I cannot overemphasize it. It is very important that the facilities where integration happens are not facilities that are overutilized, right, or near full capacity. So the spare capacity for Xpert was very, very integral for us when it comes to site selection. Next slide. So again, what test kits did we use? Like I said earlier, we started the implementation with the HIV-1 Qual, and for this one, you needed auxiliary equipment like thermomixers for the sample processing. It contained GTC, which we're all aware of, and like I said earlier, you needed incinerators of greater than 1,000 degrees for waste disposal, and this already had approval in country. However, midway in Q2, midway implementation, Q2 of 2021, we learned about the HIV-1 Qual XC, and then all the, like the previous presenter talked about, all the features and the advantages it has over the previous HIV Qual. So because of that, we decided, okay, as part of the pilot, since this was a pilot, we're going to take some test kits from what we already procured from the Qual and convert that to the Qual XC, just because, like she said, simplified sample collection, either capillary venous or DBS, and you load it directly. So there was no need for all those auxiliary equipment, because during the pilot, we had issues with some facilities saying, oh, we don't have thermomixers, and having to use centrifuge and some other mechanisms to be able to get the samples out for processing. So the fact that it was a simplified sample collection and process, it's simplified sample processing, as well as the absence of GTC, was a very strong determinant for us in piloting the use of the XC in Nigeria. It's important to know that when we used this, it just had the CE-IVD. It didn't have WHO qualification then. Next slide. So what was the impact of this work? Quickly, to the if you look at the graph to your left, you see the testing numbers that we had. And but what we need to look at is the summary we have, to the right of your screen. So before we started this pilot, the average TAT for EID tests across the facilities was between 8 to 12 weeks in the facilities. But when we did this, we saw that the TAT reduced significantly to about, for the sites where it was on site, where the testing was happening, it was within 24 hours. But like I said earlier, we had some sites sending their own samples from the spokes. So for those kind of sites, it took about 72 hours. But on the average, the TAT was 24 hours to 72 hours. And all clients that we identified were linked to care. So we had 100% linkage because of because of how quickly the results came in. And again, like I said, because it was important that integration does not affect TB. It was something that came up everywhere. We had to keep monitoring to make sure that EID testing does not impact TB. So based on our analysis, we saw that the EID testing only utilized an average of 2%, so which is not a lot. So it was because of this kind of analysis, we were able to go back to the TB program as a country to say, yes, we did use this Xpert for a pilot study. And we saw that we only used about 2% of the capacity utilization. So in no way do we expect EID samples to, take over TB testing, and then TB will be taken to the back benches. So this was a very good analysis to do because it was something that we had to use for advocacy. And we saw that before the pilot, there was no POC EID in country, but from the pilot testing contributed 6% of the POC EID contributed 6% of the EID testing during the implementation period. Next slide. So what was our sustainability? What were our sustainability plan? So far, good news, after the pilot, we were able, because of the data we have and the evidence from the study, we successfully included POC EID in our national supply plan. Recall, like I said, before this pilot, we were using just PCR for EID. After this pilot, it was included in national supply plan. And as at today, 2024, our POC EID target is 90% compared to 0% about 3 years ago. So the plan is 90% of our EID testing in Nigeria is expected to be conducted on POC EID. And now, of course, POC EID was also included in PEPFAR's COP. PEPFAR is a key donor in the HIV program in Nigeria, so it was very important that they aligned their COP with POC EID. And then in 2023, the federal government of Nigeria scaled up POC EID testing to additional sites, about 38 sites, and also procured commodities to support testing. Currently, we have, from the 19 sites where we piloted this in country, we currently have about 143 facilities that are conducting POC EID on Xpert. We also have MPMA, but for the purpose of this call, we'll stick with the Xpert. So we have 143 facilities conducting POC EID test on Xpert, and there are plans to still scale that up from the 19 that this study looked at. In terms of resource mobilization, we're exploring partnerships with the private sector, just because for sustainability, we know the donors will not always be here to see what we can do with the private sector in terms of commodity availability and market shaping. There's also been advocacy to the government of Nigeria to increase their own funding when it comes to the procurement of commodities for the HIV program. Next slide. So we'd just like to quickly acknowledge some key partners in the government of Nigeria, definitely, because we work at the service of the government, and if they didn't give the go-ahead for this wouldn't have happened. So we want to acknowledge them and the TB program, our founder, CDC, UNAIDS, and the Elmer Foundation. Thank you.
Thank you very much, Aisa. A very good stepping in there. I think this is the first time we're using the backup presenter in the history of our ECHO sessions, and great work done in Nigeria. Now, I have just a few comments to summarize what we've dealt with today before we go into the questions. Kindly keep the questions coming in through the chat. And I know that colleagues from Cepheid and Chai Nigeria are already dealing with some of them. We now know that early detection really preserves the immune function and really protects the long-term, protects people from the long-term effect, the negative effect of HIV. And there is improved survival, certainly, for infected infants when they are diagnosed early and then put on antiretroviral therapy early. We also now know that the new innovation from Cepheid does target there are two targets that are now brought into play for the detection of the presence or the absence of HIV in our infants. And that really helps alongside the early termination that then also reduces the turnaround time. But in the last presentation, we have also got to know that engaging stakeholders is really key, because then everyone falls in line right in time. But also ascertaining the spare capacity before you do integration is quite important, because you might actually try to integrate where the capacity is already exhausted and you cannot do much. You will be compromising results from the other area of your system. Now, allow me move to quick questions that have come through, and thank you again for having so many questions coming through. I'll start with one to you, Stevens. Does introducing the quality XC, the HIV Qual, HIV-1 Qual XC, does it mean that Cepheid is now going to phase out HIV Qual 1, not the XC version?
So I did answer that in the chat, but just so that everybody knows, yes, that is the intention. But of course, like with the introduction of any new product, there will be a transition period which would allow countries to ensure registration and verification in country. But of course, we strongly recommend that countries transition to the new XC product, given all the advantages that both myself and the China-Nigeria team have alluded to in today's presentations.
Thank you. Thank you very much. There is a question from colleagues here around pre-qualification. And I know that that has also been answered, but you could just again re-highlight that. WHO pre-qualification is new product.
Thank you, Francis, for this opportunity, because we are very excited, and I hope everybody on the call will be just as excited that we do have WHO pre-qualification for this product, and it will be formally announced next week. So we're very excited that we can tick that box.
Perfect. The next is still again coming to you before I get to the Nigeria team. But this is related to the waste management and the fact that you do not have GTC as a component of your reagent in this new product. And somebody is asking, does it mean that most of your products can now also be moved from the use of GTC so that then we can have ease with dealing with waste related to the Xpert cartridges that we're currently using? Or it is only focusing on the HIV-XC?
It's not only focusing on HIV-XC, that's certainly an intention of all our particularly our new products, but those that are already on the market with GTC, as those products evolve, the intention is to try and remove GTC from all the products to try and alleviate that problem. Of course, this takes time. I'm not saying all our products are going to be GTC free overnight, but it's certainly an intention and considered for the development of any new products particularly.
Thank you. Thank you very much. I can let you take a breather and I get to Jibrin or Aisha with one question that is coming in. And the question is related to the test positivity rate. So the question is, when you transition from the HIV Qual, HIV-1 Qual to HIV-1 Qual XC, did you have any noticeable change in the test positivity among the population that you were testing?
Okay,
go ahead.
Yeah, Jibrin, you could try that. I think your network is getting better.
Yeah, so I'll just go ahead and say thank you. Apologies for the challenge with the internet. So we didn't see any major challenges in terms of positivity rates with the introduction of XT. Ideally, it was just much simpler to use. And of course, we were also sending some samples being tested at Xpert site to our conventional PCR labs to just at least confirm those results. But we didn't see any dramatic changes in terms of positivity rates. Aisha, if you want to add to that.
Aisha, do you have anything to add? just for clarity?
No, yeah, yes. Like Jibrin said, there were no, dramatic changes in the positivity rate when we moved to XC. We actually saw that the positivity from the POC EID was very comparable with the PCR, the positivity we had from the PCR testing for EID. So like he said, the key thing was just the ease of use. We had healthcare workers liked it better because it was easy. Sample processing, sample collection was easier for them. So they definitely preferred it to the Qual. Thank you.
Thank you. Thank you very much, Tim. Stevens, let me get back to you with a question related to the cost of the new cartridges. So compared to what we've been using, is there any difference in the cost? But if yes,
No.
what is it? Yes.
No, there's no difference. So the cost is the same as the old version of the assay.
Okay.
And
Thank
Francis,
you.
just before
Yes.
you let me have another breather, I just do want to mention on the GTC point, of course, not all our products have GTC, and there is a list that we have shared, showing which products do contain GTC and which don't. And particularly for this audience, I think, everybody's aware that our TB assays do not contain GTC. And there are only a handful of our assays that actually do contain GTC. So just, I didn't want there to be any misunderstanding about my previous answer.
Okay. Thank you. Thank you again for that clarity. And just one last one related again to the test positivity that we've already got from Nigeria. From your own opinion, and given that this method is now using 2 targets, from the studies that you've highlighted, is there any that is indicating either difference in sensitivity or specificity of this new method relative to the old method, and what the underlying science could be?
Sure. So it's a new product, so we don't have that much data in the field yet, but we're generating a lot more as this product is implemented across different regions. But 2 studies that I did point out, publications that I pointed out in the presentation earlier, one by Dr. Bengu and Phil Gulder in their cure cohort in Durban, they actually showed that the XC was more sensitive in detecting HIV in newborns, so, straight after birth. The other study by Professor Buana, compared it to a standard of care. So there wasn't a direct comparison with our old assay. But data that's coming in would suggest that XC is slightly more sensitive, but at best it's equivalent to Qual, the previous version.
Thank you. Again, 2 quick ones. One is on availability. So is this product now available for countries to look out for them? I know that
Yes.
the WHO qualification is just around the corner, but I also know that some countries are already doing their own validation, verification studies. But from you, is the product available to countries right now?
Yes, the product is available, and as you say, some countries are already have verifications well underway. But definitely the product is available across all the markets, particularly in Africa.
And there is an interesting question related to that will you provide kits for the verification studies, or countries will take from whatever they have procured and do that, use that for their verification studies?
So that's a discussion I can't have as medical affairs. You'd have to have that discussion with your teams in country, the commercial teams. They'll be able to guide you on that.
Thank you. Thank you very much, Dr. Stevens, Gwen,
My pleasure.
Jibrin, Kama, and Aisha. Thank you for stepping in on very short notice, but I think it went quite well. Colleagues, we've come to almost the end. I'll just give a chance to the Nigeria team to give us the closing remarks for today's session before I then do the winding up. Your last parting shot from Nigeria. Aisha, will you take it up?
Okay. Jibrin, can you please go ahead? I think Jibrin's network is better now.
Oh,
All right,
okay. Great.
So Hear me, Francis. Just once again, a huge thank you to the ASLM team for the opportunity to showcase some of the work we've done in Nigeria. None of it would be possible without the federal government of Nigeria, specifically the National TB Program, and of course the HIV program. And we really appreciate all the support, of course, from the PEPFAR team, CDC especially. And we definitely look forward to continue to scale up some of the great work we've done. So thank you, everyone, and thank you for the opportunity.
Thank you to Jibrin. And I warned you the other day that I will also be in Nigeria and will be sharing the same network. So I think my being here is what actually compromised your connectivity. My apologies. But that's on the light side.
Thank you.
So colleagues, we've come to the end of this session. Thank you again very much for joining. Very exciting information coming out from Cepheid and the Nigeria team. Be on the lookout for the new product. Be on the lookout for the WHO pre-qualification listing that is coming out just any time next week, so that then you can have the basis for moving on to your transition into the new product. We also know that you already have it's probably a good amount of the old product that you can still continue using as you plan your transition to the new product. Again, until we meet during our next session from us, from ASLM, we wish you the very best of your afternoon, evening, or day, depending on where you're joining us from.